All right, I guess with the interest of everyone's time in mind, let's go ahead and get started. So welcome everybody. Um, we are all here together as for the Children and Families subgroup of the Indiana Behavioral Health Commission, we're going to just go ahead and get started with just introductions, title, and job description. And if you don't mind, if you could share what your interest is in the topic of children and families and where your expertise lies. So we're kind of going to treat these subgroups similar to any sort of a governing board, if that makes sense. So we purposely have people in here that have a really wonderful breadth and depth of knowledge and skill set that hopefully will serve as being complementary to one another. And we will be working together, spending some time together and identifying some goals, and we'll go over the rest of the agenda here in a few minutes. But I will go ahead and introduce myself. I will call on people as we so that we don't have to deal with the weird popcorn situation that happens on Zoom meetings. I'm Rachel Halleck. I am the Deputy Director and Chief of Staff for the Division of Mental Health and Addiction. Bethany?
Hi, everyone. I'm Bethany Eckler. I am the School and Community-Based Programs Director at the Indiana Division of Mental Health and Addiction, and I am the DMHA staff person for this subgroup.
Thank you. Elaine?
Good afternoon, everyone. Elaine Trepanier. I am on DMHA's Home and Community-Based Services team.
Thank you. Donna?
Hi, I'm Donna Culley. I'm the Director of Child and Family Services at Southwestern Behavioral Healthcare.
Thank you. Brooke?
Hi, my name is Brooke Lawson. I'm the Mental Health and School Counseling Coordinator for Hamilton Southeastern Schools. I'm a licensed clinical social worker and have always worked with children. So I used to work in school-based mental health, mostly in Marion County, and now oversee all of the mental health services in the school district. And I'm also a mom, so I have 2 children.
All right, thank you. Oh, my list has jumped around a little bit. Chase?
Hi, I'm Chase Lyday. I'm the Chief of Police for the Avon School Police Department and also the President of the Indiana School Resource Officers Association. Our interest is working well within the system with school-based resources, community-based resources to get kids access to those as easily and as cost efficiently as possible.
Thank you. Jay?
Hi, Jay Chaudhary. I'm the Director of the Division of Mental Health and Addiction, as well as the Chair of the Behavioral Health Commission. Rachel and I are sort of tag teaming these subgroup meetings, and so I'm just kind of here lurking. May chime in if I see fit, but just really looking forward to this discussion with this great group of folks.
Thanks, Jay. Leah?
Hi, I'm Leah McGrath, and I'm here as the kind of parent volunteer community representative. So I have no expertise or credentials. I'm a mom of 3. I'm currently with a technology company here in Indianapolis, and I oversee our marketing and public affairs. But prior to that, I was deputy mayor for the city of Fishers for about 5 years and was a part of our mental health efforts there. I've been president and past president now of the Fishers Youth Assistance Program. And so have worked very closely with bringing community partners and kind of leveraging partnerships to help provide resources, often mental health related, to stabilize the home, whether it's for the parents, caregivers, or children. So in that capacity, have worked quite a lot with Brooke Lawson and Chase with our SROs as well in the schools, who've been fantastic partners, and school resources. So really appreciate the opportunity to be here today. Like Brooke, I'm also a mom. I have 3 sons. So we appreciate all that you're doing.
Thank you. And I didn't even follow my own instructions. I didn't. So I'm a licensed mental health counselor, and I also have a 4-year-old. But I have professionally spent most of my career in family-focused treatment sorts of programs. So I have been fortunate to have been a home-based and school-based counselor. I've worked in children and adolescent inpatient psychiatric units. And most of my career has been focused on actually mothers with substance use disorder, mothers with substance use disorder who are involved in the criminal justice system, and developing programs that are family focused in nature, understanding that mental health issues, substance use disorder often have generational components, and there are a lot of opportunities for intervention and prevention that I think, by the time people, especially when I was in direct practice, get to us in the criminal justice or mental health system, I just remember working in these spaces and hearing, doing clinical intakes with people and just in my mind, just almost like doing tally marks of all of the opportunities for intervention that as a society we've missed, right? And it's not for lack of people caring or anything like that. It's very much, I think the funding historically has been very reactive in nature, and so there's a place for, of course, working with treating, rehabilitating or habilitating our young people that need help in the mental health or substance use disorder space. And I think there's a lot of space in that there for prevention and early intervention as well. So very, very, focused on kind of how do we look at the people and families that we serve holistically, and how do we, for our children that are steeped in trauma and all sorts of different things, how can we be that intervention that they need to be able to have a healthy trajectory in their life. So thank you all so much for being here. I know your time is very precious and that we're all very busy. So the fact that you're here really means a lot. So we appreciate it. So I am going to just go ahead and share the agenda. If I can find it. Let's see here. Try it again. Show all windows. There it is. Okay. Is everybody able to see that? Okay, great. So we already did introductions. So how we're going to start today is we're going to just start by reviewing the nuts and bolts of the legislation that brought us here today. I think it is really important to have that framework in order to be able to help us create the intentional direction for this particular subgroup. We are going to then open up the conversation to start talking about some broad goals that we would like to formulate as final recommendations for the commission. But also there is space within the subgroup to talk about where do we have low-hanging fruit. So I want to be really clear that if there are opportunities for intervention, or if there's opportunity for collaboration, for things that would take less effort than a full behavioral health recommendation, and then the follow-up that likely will take a long time to come to fruition. If there are things we can be working on in the meantime, there is no reason why we shouldn't get those things moving as well. And I think we have some really great people on the subcommittee, and the DMHA team that's present has the ability to pull in Medicaid or Department of Child Services or whomever else we might think is appropriate as we move along. Toward the end, we'll discuss a little bit about whether we would like to have a chair or a co-chair lead this particular subgroup. And if so, then we can talk about how we want to go about selecting that individual. And then for next steps, we're just going to talk about what we want our future meetings to look like in terms of duration and cadence, who we want to bring in, and then go over any action items that we've come up with and go from there. Are there any questions about the agenda? Okay, let me hop over to this little legislation PowerPoint. Everyone able to see that? Okay, cool. So a huge thank you at the very beginning to Bethany and Elaine, because they have really helped keep Jay and myself on focus and on track and on target with all of these subgroups. And they have helped us put together these slides and the agenda and really have been the backbone of a lot of these initiatives. So thank you all very much. So in the Children and Families subgroup, we are planning to analyze various systems that serve Hoosier children with behavioral health needs, including but not limited to school-based programming and integrated services, preventing and treating adverse childhood experiences or trauma, rapid access to high-quality early intervention, integrated care, and treatment options for children, and supports for families of children that have complex behavioral health needs. This group is going to need to coordinate with the mental health working group, of course, of the commission. But that's kind of our general, if we had to kind of boil it down to a couple of sentences, that's what we're working on. To look at the overall commission legislation language, so we have two reports. The first one was due October 1st, 2020, and I think everybody knows this, but our first report basically said there are no updates because we hadn't had a chance to meet due to COVID. So this October 2022 is when we are to submit a final report. The reports described in the legislation have to address the following issues. So we have these different sections of assessment and inventory, including suicide, mental health conditions and disorders, substance use disorders, and childhood trauma. Funding and data in regards to mental health systems, access to mental health systems, mental health providers, and funding. Youth and families in terms of suicide prevention, early intervention for mental health, and treatment for substance use disorders. System design and access, including suicide prevention, early intervention for mental health, and treatment for substance use disorder. So what you can see is that though there are some subsections, that there is a lot of overlap and there are some lines that aren't super clean. And so if we find ourselves kind of veering outside of our clean little box of work affecting children, that is totally fine if we need to bring in a different subgroup or if we need to partner with other people within or without the commission. That is absolutely okay. Additional tasks include reviewing mental health and substance abuse funding sources, and you all can read those. Make recommendations concerning funding priorities and funding levels for mental health programs and services in Indiana. Establish the cost of untreated mental illness, and evaluate the efficacy of our Dharma system and make recommendations for improving our assessment data systems. So what's mandatory that we have to check out is funding, access to care, and system design, and that is plenty. Additional assessment areas include equity, social determinants of health, data, integration, administrative burden and red tape, utilization of technology, and strategies designed to encourage collaboration, transparency, and innovation with mental health care delivery. So that's a really long way to say we are really hopeful that within this subgroup and the Behavioral Health Commission that we will be able to come together and shake things up a little bit. So thank you for giving me a few minutes to go over those topics. So I would like to go ahead and open it up to the group at this point and start talking about, as you have been thinking about this particular subgroup, what are some issues and target areas that you are hoping that we can work on as a group and where we're hoping that we would be able to make some progress?
Rachel, I really appreciate you sharing that agenda. It's very ambitious, but I can't think of anything on there that we could really take off. And I also did not follow your instructions. I apologize. I just gave my name and my title and was done with it. I'm by training, I'm a licensed clinical psychologist, and I have worked my entire career with kids and families. I've worked in the juvenile justice arena. I've worked with disabilities and special needs in another state, and certainly mental health. So, I'm excited about shaking things up a little bit. And in my current position, I have 4 teams who all provide services under the umbrella of DMHA at the community mental health centers. I have a school-based team, a team that focuses on working with those kiddos in the Department of Child Services, or Child Welfare System, DCS. I have a team that does high fidelity wraparound, which is, again, another DMHA funded program that really works with those kids and families who are at risk for out-of-home placements. And then I have outpatient services, psychiatry, kind of the run-of-the-mill clinic kind of services. And, you know, when I think about where do you jump onto this treadmill to start addressing some of these topics, I think the larger group has talked about workforce, they've talked about funding, we've talked about red tape. So I think really being able to take a look at all of those different areas and how it impacts access to care for kids and families is a lot, but I'm glad we have a subcommittee to just focus on the kid part of that, because I think everybody here, I'm also a mom. My child's graduating pharmacy school tomorrow. So
oh my gosh.
yes, I know, we're just very excited. So yes, I think we all have a heart. We're all in this work together in different ways. So yeah, I appreciate the agenda. I appreciate being a part of this. Do I have solutions or ideas where to start? That's where I'm feeling a little overwhelmed. But it's all good stuff. And I can't think of anything that you presented that we really, you know, shouldn't tackle.
And I think I appreciate you mentioning that. And I think one thing to make sure that the group as a whole understands too is this is not necessarily just for DMHA clients. So DMHA typically serves individuals that are on the lower end of the income spectrum. So I did want to say, you know, one of the issues in terms of parity in terms of access to services, right? We have school-based services for people who can be covered by Medicaid, but you know, commercial insurance doesn't typically cover that. And
Exactly.
So that's another issue that I think is really significant. There is space to talk about here as well. And real quick before we move on, Christy, you popped on and we didn't get a chance to get your introduction. Do you mind introducing yourself and talking a little about your role and your area of expertise when it comes to the realm of children's mental health?
Yeah, sorry. Can you hear me okay?
Yeah.
Sorry, I was on finishing a call with the school. Yes, I'm Christy Berger. I'm the Director of Social, Emotional, Behavioral Wellness for the Department of Education. So I have a team of myself plus 5 individuals, and we support schools in SEL, mental health, trauma responsive practices, really trying to help be a connector between schools and local mental health providers to get school-based services for students. I am a school social worker by training, spent 10 years in the field. So SEL and mental health are huge passions of mine. And then I also lead the Education Outcome Task Force for the Commission on Improving the Status of Indiana Children. And part of that is also addressing the gaps with school-based services for students who are in need of support. So excited to be here. Apologize for my tardiness.
No worries. We totally understand how that goes. And one thing, just another thing to mention here is don't be afraid to think big. I think sometimes we can get stuck in our boxes because of our funding sources and our streams and things like that. The subgroup and the Behavioral Health Commission truly is a space to start coloring outside the lines a little bit and talk about, you know, I'm sure we have a lot of clinicians here on the call, and we are familiar with the magic wand question, right? Like if there weren't any of these barriers that you're dealing with on a daily basis, what would the perfect system look like? And I don't think that our outcome from round 1 is going to be developing the perfect system, but I think we have an opportunity to get a lot closer to it than we are now.
So you asked the question, I can't remember the point on the agenda, but, you know, identify broad areas that we'd like to cover. And I do think one of the things that we've seen a lot of just local success in Fishers, and that's with the collaboration that happens between HSE schools. And then I do think with the Fishers Youth Assistance Program and having those kind of frameworks in place that allow early intervention to happen and for collaboration to happen between, you know, community partners, whether these are kids who are eligible for Medicaid or not. And I think that that's something, if you think big, that I would love to see happen across the state of Indiana, is to put these frameworks in place. And part of it's funding, without a doubt.
Mm-hmm.
But part of it is also just helping stand up the frameworks to allow for the, you know, this to occur.
Could you talk a little bit more about how what you have happening there is the gaps that it has filled and how it is different than access, kind of status quo access? What have you developed that is different?
So I will not try to cover what the schools are doing because I'll let Brooke do that.
Uh-huh.
I can speak to some of the community partnerships and connections, and Brooke can probably elaborate on that. But through the Hamilton County was one of the first in 2011 to institute the youth assistance program. And that happens, it's done through the judicial system. So it's a prevention program, if you think of it that way. And it was really about, hey, we've got a lot of it. Steve Nation is the founder of it, Judge Steve Nation, who is retired now. And he would say, you know, he's got a lot of kids coming before him in the juvenile court. And many of them, maybe not all, but many had had something happen in their lives earlier. What if we could get around that? And at that point, support the family or those kids so that they could stay on a healthier trajectory. And so the data is actually astounding, and I can share it with you. Since that program, even though Hamilton County has seen an increase in population, the number of kids going before juvenile courts has decreased dramatically, significantly. It's working, and what it's about is getting in when there is, and so we have a very close relationship with the police officers, the SROs, the school counselors, so that referrals can be made to there are social workers who are employed by the court, by the Hamilton County judicial system, so that those early intervention advocates can get in there and understand what's going on and how can we help. And it's really about connecting to resources, for the most part, that already exist. It's sometimes holding someone's hand and literally saying next to them while they complete paperwork to see if they are eligible for Medicaid or whatever the resource is. It's a lot of begging, bartering, and pleading with community partners when insurance doesn't cover something, and how can we get assistance. Mental health is not always the issue, but often it is, and sometimes it's the kids, sometimes it's the provider or the caregivers. I can tell you that in HSC schools, in Hamilton Southeastern schools, we passed a referendum in our community that provided school counselors in every school. And when that happened, there was a question as to whether we would see an increase or a decrease in referrals for youth assistance program. We actually saw an increase, because now that you've got counselors in the schools, you can have that. There was even more identification. So even though now it was helping with the triage, so I think we're serving more kids collectively together because of that, there were still referrals being made for other services. Then, and this would be the last thing, and I'll hand it over to Brooke, but there's a collaboration between a couple different nonprofits and the school foundation, where we have a fund called Project Hope, where we are all contributing dollars, and it really is like a stopgap, or it helps get kids who maybe don't qualify for Medicaid. Right? They can't afford private pay. We all know there's not enough counselors accepting insurance. So how do we help get these kids the benefits that they need? And so, or the services that they need. So this is like a scholarship fund that helps pay for their counseling through a partnership as well with community health. So the way that we've done it, though, is it's just been a community conversation. Any judge in any county could start a youth assistance program. It's probably funding is going to be a question, right? Because you got to pay for the employees. And then the nonprofit. So I've been in part of the nonprofit from the community standpoint. We basically raise funds to support all the other stuff, right? If there's stopgap services, if they need a hotel to stay in for 2 nights before the shelters open, if they need the first 2 sessions covered until their Medicaid eligibility comes through, we're paying those stopgap services out of donations we raise locally through the nonprofit. So that's a 30-second version of what could be a 30-hour conversation, or 3-minute version. But Brooke, I'll let you fill in. I'm sure I missed quite a bit there.
Well, when I came to HSC and sat down with youth assistants, I remember thinking, like, my word, like, what a great program, and how helpful that would have been in the districts I used to work in. So I would compare, like, in the mental health world, they're like preventative case managers, and the
Mhm.
family doesn't have to have, like, there is no criteria. We can make a referral to youth assistance for really anything. And they really, what's so great is they can kind of wrap around the family, and there's all kinds of support that they can provide to the family. They have relationships with our YMCA, and they're able to get kids into clubs over the summer and things of that nature. And they work really closely with our mental health providers in the schools. And so as you were talking earlier, Rachel, I was thinking like, well, my wish list, number one, it would be that 8 to 10 years wouldn't lapse before a kid got services, right? And so, when we think about kids that are starting to struggle, and we have school counselors and we have mental health therapists in all of our schools. And, prior to having mental health therapists in our schools, every time we had a kid where the counselor's like, I just don't know what to do to help this family, it was, we'll call youth assistance. And so, they are extremely helpful in connecting families. And again, like when I think back to my days in community mental health, like there were so many families that could use some case management, right? Somebody to help connect them to all the different things that they needed. And that's really where youth assistance fills that gap for us. And they're a part of the wraparound teams, and, they're often able to do a lot more and just build really close relationships with the families that they're working with. So youth assistance is, really, really helpful in our community. And I would say all of the other Hamilton County school districts would say the same thing, although I'm partial to Fisher's Youth Assistance. But I also, as we think about mental health for everyone, and we think about like, how do we raise mentally healthy kids in Indiana? Like, the thing that always pops in my head is social emotional learning. And I know there's so much chatter around what that actually is, and what we're doing with students, but there's strong research to support this work. And I think it would be really sad to me that this group wouldn't make some recommendations around that, because we know that kids need these skills in order to be resilient when they face difficult challenges. And so I think that's something that we should talk about. We know the research. We know what the research says about that work and how important it is. So that's another just item on my wish list, is that would, I know the IDOE has done a lot of work around social emotional learning, and we have competencies as a state, but including our mental health agencies in that work as well. And they really are our tier 2 and tier 3 supports for schools, and social emotional learning should be that prevention, that tier 1 approach that all kids should be learning. And as a parent myself, my own child is learning this, and it is like a wonderful thing. He gets a lot of that at home too, but to hear the conversations that are happening at school, and for him to tell me, I'm tipping out of the green zone, Mom, I probably should use a strategy. Like, those are really important things that I think our society as a whole has not focused on, and is potentially contributing to some of the trouble we're having.
If I may, Rachel, I guess include my sentiments along the same lines. The first is hearing Leah talk. In one end, excites me. On the other end, it angers me, because that program for youth assistance is what we all aspire to, and I'm jealous of it. And many of us in the state are jealous of the Hamilton County Youth Assistance Program, because you have officers, behavioral health professionals who want a structure and they want a model they can follow. They want funding other than, hey, let's add it to someone's job, because then it's not done very well. But we don't have a statewide model or a few options for what models could look like to get kids the resources that we want them to get at the early intervention stage. And I know that this kind of moves on to another subcommittee a little bit with how it interacts with the criminal justice system, but my interest is not adults in this situation, it's kids, where we talk about the criminalization of our kids, or a school to prison pipeline that occurs because of various factors. But the reality is we have profession of school-based police officers, at least, who are saying we recognize the need to get kids early intervention and to get them supports. But then we look at our state crisis and they are not there. We don't have a model to say, hey, here's something else other than arrest them. We don't have funding to say, okay, we have a great program that we can model after in Hamilton County. Let's hire someone to do that. There's not adequate funding for that. And so I know that I echo the sentiments of those on this call, but there is a significant appetite for those resources, and at least for the model, even if we needed to be creative in how to pay for it ourselves in our own school budgets, even a model is missing from what I can discern. I see some in other states. I've recently studied Connecticut. I've recently studied Iowa. I've recently studied Massachusetts. There are some models that exist, but we don't have one in Indiana from what I can discern. And then the second part of that is at the prevention stage, at the tier 1 stage. Social and emotional learning is also a passion of mine that I think is seen by some educators as, yeah, that's kind of soft and sweet and nice, but I think there's a bit of a disconnect between the impact that it has on academic achievement and also some of the behavioral challenges that we're having to overcome and throwing a lot of different things at. But again, as Brooke said, there's such a strong correlation between academic achievement, more positive outcomes, school connectedness, all of those things that educators should be primarily focused on. Again, the recommendation to utilize those materials, I think, are missing in some components. And so what my suggestion is for both of those sets of issues is that we would consider modeling, or we would consider being clear on which models might be appropriate in Indiana to use. And I'm not saying we copy and paste, anyone else's issues, but I am saying that we thoughtfully consider what those gaps are, so that our goal is to provide modeling for school districts and not just ideas. Ideas become disjointed. I think a model and how that model fits comprehensively is usable, it's actionable.
So what I'm hearing you say is that the many school districts are understanding that they have their list of needs. They just don't know how to strategically implement a solution. Does that sound like what you're saying?
That's exactly what I'm saying.
Okay.
Here, and even in my own community here in Avon, we have a massive amount of community resources. We don't have a lot of school-based resources, and access to even our school-based behavioral health resources is very difficult to obtain. But the community resources exist. But for us to be able to galvanize all of those and to collect all of them into a format that is recommended and potentially funded in different ways, that is what I'm asking for, is for there to be a model. And not just for myself, by the way, but because I want to champion the Hamilton County Youth Assistance Model in other areas. I saw Christy mention the Metropolitan School District of Warren Township. I had Mr. James Taylor from their township come and speak to a conference of school resource officers last year about this exact topic. There is such, and it was the best attended and best received breakout session that we had. I'm saying there's an appetite for this across the entire state because we have resources, we want to help, but we don't have a model that we need to follow or a plan on how we attain what Hamilton County has done.
So real quick, I would like to hear Christy talk about what she shared in the chat. And then I would like to back into kind of, if we can answer the question that this particular model, the Youth Assistance Program in Fishers, what are the gaps that it is filling? If we can back it up and help be just a little bit more specific, because I think if we can boil it down to there, that might help us nail down some specifics as well. So Christy?
Yeah, so Department of Education, in partnership with, oh my gosh, her name just left me, a senator that I can't think of her name right now, we met, discussed a youth assistance program, talked with Chief Justice Rush. That was a priority of Dr. McCormick's, was to create these, like Chase is saying, these demonstration sites, these pilot sites. And so we had funded 4 youth assistance programs for last school year, but with COVID, obviously, some of that funding got extended to this year. However, that priority is not a part of our current administration, therefore it wasn't continued to be funded again next year. But I would say that we worked with a couple of the school districts and had some funds out of the health department, because this falls in line with the social determinants of health and being intentional in providing prevention. And they were able to help us get some funding to help those schools continue this work while they can build it up in their community to really take the ownership of that. And I'm forgetting the fourth school, and I'll think of it, Chase, and I'll add it in there. But in addition to talking about that, Brooke, HSD, and then 10 other districts are a part of a grant that we host with DMHA, the Project Aware grant. And the purpose of that grant from SAMHSA is to create demonstration sites around school-based mental health services and supports and what that looks like. Our focus is prevention. Our focus is social emotional learning. And we have a variety of school districts, from very small schools to very large schools all over the state of Indiana, working to implement what this looks like in their space. And our hope from that is to share out with other schools what that piece looks like. What does school-based mental health supports look like? And we did just apply again for an additional round of funding through SAMHSA to even extend the Project Aware sites past the 11 school districts we have right now. And I mean, I agree with Chase. I think a lot of schools just have a variety of competing initiatives. And so being able to figure out how and what this looks like in their space, while they're also, having to stay in line with state testing and state standards. And so being intentional with that work. And I think what we've continued to find out is the gap of services is similar to what Brooke was sharing. In some of these districts, the students don't qualify for state insurance. So then we know that data says kids are 6 times more likely to complete treatment if it's done at school, but a lot of our students aren't qualifying for that, or there aren't mental health professionals to provide that. And so looking at those types of gaps, or looking at our CMHCs and seeing, can you all partner with us to provide prevention programming? And I know, talking big in dreams, we've talked about looking at our Medicaid plan, and is there a way that we can rewrite it to be able to provide prevention services, not always just reactive services. And so looking at that space, I think, would be really beneficial, and really being able to provide those services throughout the school day. Also, some of our schools in Marion County have started to have school clinics in there. And I mean, it's kind of a one-stop shop for some families, and they come and do all these things, especially in some of our rural counties. We've seen, the school is kind of the lifeline of that community. And so how do we juggle all that's required to support a child and their family, with the academic day being what it is and extending past that? So that's a little update on the couple of things we have going on from the department, where we're really trying to continue to create these demonstration sites to focus on what does school-based mental health supports and services look like. And we are seeing with a lot of resistance. We are seeing with a lot of that this isn't the school's role. And so we're saying our data shows that it is. And a small celebration would be, I think we're going to actually have weighted YRBS data this year. We got 43 schools to commit to doing the YRBS. So that will be good for the state of Indiana to be able to show where our students are. But just, again, really being intentional with those proactive services, I think, is going to be vital for success.
What's the tone of some of the resistance? Is it capacity related? What's kind of yeah.
Sure. So the resistance from schools possibly would be just, again, finding time. And so we from the department have tried to show how SEL should be done in line with academics. So we've crosswalked the middle school academic standards to our Indiana social emotional learning competencies. So when you're already teaching math skill 2.2, you can also teach this SEL skill. We've tried to create some pre-packaged items for them. There's a big push from a group of parents right now and some legislators that they don't believe that this involves or should be done in schools, that this should be a home issue. And then again, just the stigma around the mental health supports.
Okay, that's helpful to, and of course at DMHA we've stumbled into some of those things. I was just curious, and I think generating buy-in in a group of people that are already really maxed out is I think a particular challenge of what it is that we're trying to do. And I have a separate initiative that I'm working on around, just kind of as a parallel, around early screening and intervention for pregnant mothers who are using substances or at risk of using substances. And, you know, a lot of the first concern about medical providers is where am I going to fit one more assessment in? You know, and it's not about sometimes it is, but usually it's not about not believing in it or not caring about it. It's just how in the world will I actually do this in practice? And I think as we're conceptualizing our magic wand, I think that capacity is perhaps one of our biggest barriers to be thinking about. So yeah.
I will say though, around capacity, you know, in our district, we have a scope and sequence that every school is following. And our teachers are actually saying, like, I'm having less issues in my classroom because I have a language that, like, I used to send a kid to the counselor because I wasn't quite sure how to help them through this problem or support them. But now I am able to handle it within my classroom. And so I think that definitely capacity is an issue because our teachers are spread so thin right now. But I also think that once they get the practice in doing this, and a lot of good teachers naturally are supporting social emotional learning every single day in their classroom. They're just not calling it that. And so, you know, in our district, it hasn't necessarily been teacher pushback. It's more what we're experiencing right now is community pushback.
That's very helpful to know. And I wonder what research exists out there around how, you know, if there are any trends around, is it like familial pushback? Is it capacity issues and things like that in terms of rural settings versus more, you know, city focused settings and how funding of the schools impacts that. I'd be interested to see some things from that. In terms of the youth assistance program, what are the primary gaps that program is bridging? We've talked about some of them, but I do want to be specific so we don't miss any.
So you're wanting to know the gaps they fill in our community?
Yeah. Mm-hmm.
So they fill a lot of different gaps for us. So a lot of it, you know, they actually oversee all of our like food insecurity stuff. So they do our snack attack program. They do our summer meals program for students because we're not a high free and reduced lunch school district. We don't have lunches served in our schools over the summer. And so our youth assistance program, it oversees all of the summer meals programs for families, but they also do a lot of casework. I mean, they're connecting families to resources, whether that's insurance. So let's say the family has no insurance provider. They will help to connect the family to figuring out what type of insurance they might be able to access. They will connect them to, you know, if the parent needs help trying to find a job, they help work with the parent on that. They, you know, they'll help with childcare needs. They'll assist the family, like they'll help assist getting the kids involved in different community activities so that they're not engaging in maybe other activities that could get them into trouble. You know, there's such a broad range of things that they assist with. It's hard to name them all. You know, if there's rental assistance needed, they're helping families with that. You know, connecting them to the trustee's office. At times they're attending IEP meetings and helping support the family in that. So it's just such a wide range. Leah, I know you just jumped on, but Rachel had asked kind of what gaps youth assistance fills.
Oh, there we go. Sorry, I was listening. You did such a lovely job answering that question. It is so. It's really about you know, whenever there's a referral made. And that referral could be self-referral. It could come from a school counselor, a teacher, I think now it comes mostly through the counselors. It could come from the police if there's truancy issues. It could be however the referral is made. There's really then, it's triage. It's absolutely casework by those early intervention advocates who are employed by the county under the judicial system. And that gives them the ability to really kind of understand what's happening and what supports are needed. And sometimes it's, hey, I just need to connect this family to a resource and they're good to go. Or it could be long-term support. And, just making sure that, there's wraparound. I describe it when I'm trying to get volunteers or community members to get involved in the board. We're trying to collectively wrap around our arms around these kiddos to help them be, everything that they can be. And so often it's always it's in coordination with the schools if it's a child who goes to the public schools. But in terms of meeting the needs, it's everything that Brooke outlined.
What's the just ballpark number of staff, number of volunteers?
So on any given day, we have between 200 and 250 kids who are on kind of have an active file with our early intervention advocates. And in the city of Fisher, or for the Fishers Youth Assistance Program, and it's countywide, but I can speak more about the Fishers side. We've got 2 full-time early intervention advocates that the county pays for. The city also through an interlocal, and the schools historically through an interlocal have also contributed. So it's kind of the position and benefits are paid for collectively by the government, the local governments and the schools. And then we also have a part-time office coordinator who really helps with, triage and making appointments, and then also supporting the board. Mm-hmm. And that office coordinator is paid for in Fishers by the board, by the nonprofit. Then for the board, we've got, I think, 17 or 18 board members, but then our volunteers, we have an army of people that have just risen to the occasion. And I put in a chat feature because it takes time to build these relationships. So I'm so disappointed that the pilot funding didn't continue, because it takes time for the early intervention advocates to develop relationships with all of the other, community providers, as well as the, you name it. We have a partnership now with Connor Prairie, who offers scholarships for camps, things like that. So that takes time to develop, but it also takes time to develop your community champions who can help raise funds, raise awareness, and make those connections. So I would say overall our volunteers, probably easily 100, probably more when we add them all up.
Thank you. And so when we are doing models of this across the state, and then I'll back away from the youth assistance program so we can talk about other things too. But when you all are doing this work around the state and have funded it in a few different areas, so it sounds like there is not any sort of, at this point, any sort of like manualized approach to this. Is it just that we are funding with a few grant check boxes that we want to make sure that are covered, and then each individual program can kind of develop that out as they see fit in their particular area?
I think first, before anyone uses their expertise, which I do not have in this area, I would say that there are different types of models run by different entities. And so you've heard a couple, even from Leah, that there's a private and public partnership that exists. Yeah. There's another type that is a school-based type, and then there's another type that seems to have a lot of efficacy or showing efficacy is the court-based program. And I think the intention, again, is to have a model that allows kids access to these resources, again, at an early stage, but affordably. Meaning right now, the ramifications of not having this model in a state, or not having even an idea of how to get started is what I hear from a lot of counties as police officers or as school resource officers are, hey, we want to get a kid help, but the only way we can do that is if we arrest them, and the prosecutor's office is the one that refers them to these resources. And so then school resource officers are criticized and say, all you're doing is arresting kids, but that is the only option that a lot of school resource officers know about. And it's frustrating to say that we have to attach criminal charges or dangle criminal charges over somebody's head to get them resources. But even so, even as you begin to share these programs with different entities, prosecutors, public defenders, behavioral health providers, there's not really an agreed upon model of what they should do. And maybe that is locally driven, but there's not a model, I think, that we should champion. It would be what's best in your local community, but here are some models that you may consider. But again, I would say the ramifications of not having these models would be detrimental to kids long term.
Thank you. That's very helpful. Okay. Okay, this has been very, very helpful. So what other sorts, as we've been talking about this, I appreciate you sharing this idea of the youth assistance program and how that could be, my wheels are turning about scaling this and what that could potentially look like. What other sorts of things are you seeing in terms of gaps, needs in the community, in those sorts of things? What all are you seeing?
So I'll throw it out. Just one thing I'm hearing kind of across the board is kind of lack of inpatient or triage type of like beds, especially for youth and adolescents. I think that's very different kind of community to community, but I'm just wondering if anybody has any insight into the kind of the scope or scale of that problem. I mean, and if not, we can probably find somebody to come to a future meeting that's an expert in that area.
And I think, Jay, correct me if I'm wrong, it's been inpatient, group home, and even respite care. Is it?
Yes.
Right?
Yeah, kind of across the board. And it's a problem regardless of age, but I think it's especially acute on the youth and adolescent side.
I would add to that, not only like inpatient, but there's a huge gap between outpatient and inpatient, right? So like, IOP programs, PHP programs, there's not much available, especially for students under the age of 13. And so oftentimes, we try wraparound, but kids have to qualify for that, and some students don't. And so, those types of programs are really helpful for children. And I would say I'm in the Indianapolis area and we don't have much to choose from. So I can't imagine what smaller communities, rural communities, what struggles they're having in that area.
What is the nuance around the ages 8 to 13 that is particularly problematic?
Like in our area, like you mean like what struggles or?
Well, correct me if I'm wrong. I think you mentioned especially for kids ages 8 to 13. Is it that most of the programs serve teenagers? Is that okay? Yeah,
so they don't even really exist.
Got it.
Like there was just in the Indianapolis area, there was one that existed, and a couple of months back, they weren't even taking younger children. So that's.
Do we know if that's different in other states?
I think the trend has been away from institutional settings, especially for young kids, just kind of across the nation in terms of, trying to keep families united, trying to develop more community resources. I think there is a place where children do need a higher level of care. And then when that's the situation, accessing that higher level of care. I know here in the southern part of the state, we have EPCC, the Evansville Psychiatric Children's Center, and it's an inpatient, relatively short-term stay, meaning 3 to 6 months. And we serve those kiddos that are at the highest level of need clinically, that are under the age of 12, 13, depending, if they can squeeze that person in based on their dynamics. But down here, if you need something that's not as intense as a psychiatric hospitalization, we have nothing. I mean, there are no private, PRTFs, the private kind of residential programs, group home placements. And when those beds are available, we've got competition among our state agencies, if you will, a little bit. DCS could pay a little bit higher rate and guarantee some beds. And, so I think we do compete with one another. I mean, we don't place children, but in terms of helping families seek those kinds of resources, it is very challenging and it's very limited. I've worked in other states, most recently came from South Carolina, but it's been 10 years ago. I don't know what their current climate is with respect to that issue, but they did have a network of, private, not-for-profit, kind of acute care kinds of short-term assessments that allowed families to have some of that respite, but also allowed for the clinical work to be done so that they could identify appropriate treatment options that would be helpful on a long-term basis, but the child would not be residential long-term. So I think there are some ways that we could explore some additional resources in Indiana that we just, I mean, to my knowledge, again, in the last 10, 11 years, I haven't seen it.
And Donna, so I'm assuming at your organization, the programs don't exist there either, right? Is that right? And
No.
If you don't mind, I'm asking you to be candid. If you don't mind, kind of just letting the group know if you do know, what is the barrier from Southwestern's perspective to, because that you obviously see the need. What's the barrier to having Southwestern fill that gap in your area?
I think the two biggest barriers would be, I mean, it's an entirely different animal to do outpatient therapy versus residential treatment. We'd never get adequate funding and the administrative burden would be overwhelming.
For the residential in specific? For
a residential program to be tacked on to what we already have to do as a community mental health center.
Do you mind if I ask, just to be even more specific, what the administrative burden that you're referencing? What are there any
licensing? You'd have licensing, you'd have liability, you'd have payment structures that you would have to explore. I mean, to do that body of work is really very specialized. Hillcrest Washington Youth Home is a youth home in our area. I mean, we have 2 youth homes in our area, and the nature of their regulation and finding staff to staff them, and I mean, there's just so much that would have to be done to add that totally different layer of service. I mean, I'm knocking on the door of retirement. I'll never see it before I walk out the door because it is just enormous. I think there may be one community mental health center that does have a sister program that is an adolescent group home, Oaklawn maybe. I don't know if they still have that partnership. I'm not saying it's not doable. I'm just saying that overcoming the barriers with everything else would be something that would have to be planned for.
Is it something?
The reason.
Oh, go ahead, Jay.
The reason I brought that up is because as we think about what this commission ultimately is able to do, I mean, that's the sort of thing I think we need to swing big and say, like, number one, there's a need, right? And number two, here are the specific things that the state and other people should do to unlock the door to these sorts of things. And I think we have the opportunity to do that. And so that's why I think Rachel was interrogating you about the specifics, because I think the more and more we can get.
I hear you, Jay. Yeah, no, I've had staff that says, okay, if we could only open a group home, if we could only offer this service. I mean, and it's like, oh yeah, I mean, we definitely, I wish there were options that would, that we could identify and pursue those other layers of care. I mean, when you think about the continuum of care, we do want to keep kids at the least restrictive clinical option that meets their needs. But I mean, we have kids that we serve and it's like, oh my goodness, this is not an adequate situation. And then, finding those higher levels of need, even if for a short period of time. I've had staff say, okay, if we could only do our own group home, then, we could make those referrals and we could have that avenue to provide those services. I would love to see that happen. I don't know if it has to be within the confines of a community mental health center. But there may be other, like I said, not-for-profit entities around the country who offer that service and who do that. Would be willing to come here.
So Donna, you might remember this because back when I first started in community mental health in 2019, I think it was. We had, so like, I'm not talking group home residential facility. I'm talking partial hospitalization, day treatment programming. We used to do that all summer in our summer program. We had like day groups. And the funding changed in 2009, I think it was, where then we started getting packages, right, for students. We had to do the cans, and it might have changed because it's been 4 years since I've worked in community mental health. But were you working in Indiana at that time when the funding changed? And no, we couldn't do partial hospitalization programs anymore. We could only meet with our clients one-on-one, because from a funding perspective, we lost money.
Yes, I came right on the cusp of that change, but historically we had what we called youth day treatment program, and it was a partial hospitalization program. And we worked with those kiddos that were not able to benefit or function well in a regular academic environment. So we had a partnership with our local school district. It was an extremely beneficial program for those children. We maintained that by switching over and very carefully billing MRO for individual and group skills in partnership with the teachers that were in the program. So we made that shift for a time. But since then, we have dissolved that, and now we are embedding all of our services within the schools themselves. And again, there was some shifts in philosophy about, do you pull children out or do you keep them in and provide services in more of a normalized school environment? So I think there's been some funding changes, there's been some philosophical changes that have caused some changes in that programming. It was great programming, and I think there is a place where that can still happen. But I know those are some things that shifted the partial hospitalization programming. I think now you're looking a little more at some intensive outpatient models that I've seen pop up. But again, those are pretty few and far between, especially for the younger kids.
So I definitely think like a good tagline for the commission could be, making your if onlys come true. So look at, but in the interest of moving on, I think we should just maybe put a pin in the notion, Rachel, of additional settings or gaps, and like probably drill down and maybe possibly for our next subgroup meeting, maybe get somebody to come do a deeper dive on some of those things. How does that sound?
Yeah, that sounds good to me. Yeah, no, this is really helpful. So the kind of buckets of interest that I have been able to whittle it down to, we'll see how I did, was social emotional learning, a need for some sort of access to some statewide models that can be tailored to the specific needs of the community that it may be launching in. And then increased need for inpatient group home respite, and then addressing this gap between outpatient and inpatient. And it is a pretty stark drop off. I mean, it really, really is, that drop off that's happening there. My last question would be, where do we feel like we are in talking about the burden, the extreme burden and being spread thin that teachers experience? Where do we think that we are in terms of teachers being able to serve kind of as the front line of identifying behavioral health needs and getting students connected in the right manner? Because I know, and this has been 10 years ago when I was doing school-based work, a lot of times teachers didn't feel like they had the training or the expertise to be able to name behavioral health things. And then a lot of times we were inadvertently missing students that could really benefit. What's this group's thoughts on that being a potential focus area?
Rachel, are you considering training for teachers to recognize?
Potentially. This is about a half-baked idea. I'm not, I don't really have the solution yet. Just wondering
I think that may change the outcome of some disciplinary procedures and potentially more appropriate referrals. I actually haven't considered much of that. So I was curious on what context you were framing the question. I would certainly say that could be beneficial.
The framework that I was coming from was essentially, so most of my work has been in the correction setting, and we did a lot of training to say to our correctional officers, if we can see this as a symptom of a behavioral health need rather than a infraction, our response is going to have both greater long-term and short-term positive effects on us and on everybody, basically. And whether or not there is a similar need for to help with training and some training, number one, and then number two, making sure the resources are there, because you can train all day long, but if the teachers don't have anything to help them, I mean, then what? But yeah, training in terms of identifying, how do I tell that something might be a symptom that the client's struggling with a trauma, a social determinant of health, or a mental health issue versus just suspend them, I guess.
I think that's an excellent idea, Rachel. I think teachers already have, if I had my wish, we would train every single teacher in mental health first aid, but that's an 8-hour training.
Yeah.
And so that would require a substitute teacher. So there would be money for the training, money for the substitute. Yeah. And, teachers already are overloaded with state required trainings. It seems like every single year we add one more thing to the required training for school employees. So I'm with you on, early identification. And we try really hard with our community mental health partners to do some of that in-house training when they're, when the school year starts, reminding the teachers of these are the kind of students that I can support you with and help you with. If we had the funding for subs to come in and cover classrooms for 8 hours so that all teachers could get mental health first aid training, it would be less of a barrier. But again, it's still, I think, a barrier for school employees.
I wonder if we could incorporate some of that training into teacher education. I mean, I hear what you're saying, Brooke, about pulling them out of the classroom right now. It's not an immediate solution, but as we're building the boat for where we want it to sail across the ocean, I mean, I think bringing those kinds of topics to bear on those curriculum for those new teachers that are getting trained now, when they graduate, they'll be much better equipped to be prepared to do the social emotional learning, to identify trauma in those kids that they're going to be working with. Like I said, long-term solution, but if we could, maybe make some recommendations for some of those kinds of changes, eventually it will trickle down.
So I just put in the chat, SEA 205 did add SEL and trauma to be included in teacher prep programs. So not mental health specifically, but those two. But
did it pass?
Yeah, that's what I was told today.
Well, that's exciting.
Great. Now I'm going to double check. I was told.
Christy's nervous now.
Can we take credit for it?
Our job here is done.
Yeah. The thing that is around that
should at least go in the report.
Yeah, absolutely.
It doesn't say to those higher ed programs what or how they should teach, and or it's not going to be monitored. So
baby steps.
Yeah.
Okay, cool. Well, the discussion today has been really, really good. So the next thing for us to talk about, and Jay and I may have different opinions on this, so we'll see how it plans out. We didn't touch base beforehand. Jay tends to be of the mindset. What'd you say, Jay?
I'm excited to see if we're on the same page here.
So Jay tends to be of the mindset in smaller groups, we don't necessarily need a chair. I tend to be of the mindset that this is not a DMHA, like the outcome of this subcommittee is not to serve just DMHA. And so if we had a different person chairing it other than me, I'm happy to, that it might have a kind of a broader perspective or broader scope. So I guess the first question to the group is whether we think it would be beneficial to vote for a chair. If we do have a chair, the way that we've done it in another group is basically you can opt out of being in the running for the chair, and then we take whomever is left, do a little online voting, and then reach out to the people that got elected as the chair and start working with them to kind of drive the focus of future meetings. So what are people's thoughts? Jay, how'd you feel about that?
No, I think we're on the same page.
Is that cool? Okay.
Yeah, I think for a couple of the other ones, there was more reasons beyond just the size of the group. So I think that.
Oh, okay, cool.
In this case, I think a chair might make sense if the group agrees.
Okay.
I think a chair would help us stay on point and keep focused on our goals. I'm opting out, just to say.
Okay.
But you've done a great job, Rachel. I mean, if you said you were willing, I don't want to volunteer you, but I think it will help keep us focused, help corral the efforts of this group.
Thank you. So what we will do, unless anybody is very actively anti-chair, so you can side email if you hate the idea of a chair. What we'll do is if you would like to opt out, just shoot myself, Elaine, and Bethany an email this Friday. To chair this group, I don't anticipate being a huge time burden. I think it would be simply working on prepping agenda and just delegating tasks as we need to moving forward. So we, Elaine and Bethany, Jay, and myself would be able to help offer support in terms of organizing things and strategizing and reaching out and stuff like that. So don't feel like you'd be just totally flying solo, just as an FYI. Does that sound okay to everybody? If you're not interested in sharing, shoot us an email by close of business Friday and opt out. Okay, awesome. So it sounds like that is our main action item. What else, Jay? Did I see you start to talk?
No, I think that just kind of like to bring it to how this has been, I think, a very, we've been inventing this kind of whole cloth as we go on. And so, I think it's working out really well so far in terms of the subgroups and the sort of trying to drive everything that's so complicated. I think Leah said you could probably talk about this for, 30, 40 hours, right? But, I think our plan is to maybe, meet one more time with each subgroup and have kind of like both an idea of like the direction for the bigger recommendations of the commission, as well as identify some lower hanging fruit type things to move on by the end of the next subgroup meeting. So does that seem feasible to folks, or do you think we need to go a different direction?
I think that sounds fair.
Okay. Yeah, I agree. I think that everybody so far has been so just like solutions focused and oriented. And I think that it's just been wonderful to see. So I'd like to just thank you all for that.
Yes.
Only thing I would add is, do we want to find a meeting date while we're all together right now, or do we want to wait until after the chair selection process? I know finding a date is always better, quicker, I think, to get it on our calendars. Okay, so I think I got thumbs up from a couple of you. So I think, do we want to look into June? I think we've been going kind of a couple months out just to give us time to kind of wrap up and get our action steps together for, between meetings. Anybody want to throw any dates out? Or any that are off limits totally?
Are we thinking the same time?
We can, if this time works for everyone. We were able to get our full subgroup onto for this meeting. So if this same time works, we could do, what is it? We could do like the week of the 14th or 21st on a Wednesday at 3:30. So it's the 16th or the 23rd.
I could do the 23rd. I have a conflict with the 16th.
I could do the 23rd.
I could do the 23rd. I'd vote to meet a little earlier.
Okay.
Because I don't work as late in the summer. I would work late for this meeting, but
What does everybody think about like a 2 o'clock?
Perfect.
that
Like 2
works.
to 3:30.
2 to 3:30?
2 o'clock Indy time.
Yes, Eastern.
I always have to get that straight in my head. That works.
So June 23rd at 2 to 3:30 Eastern time. I'll be sure to make that clear, or we'll be sure to make that clear when we send things out. Great.
Thanks, Bethany. All right, well, we are getting close to the end here. Does anybody else have any last minute thoughts, anything that they'd like to share before we close?
I would say quickly, Christy, I think it might be important for your work also in the commission and improving the status of children in Indiana, that we kind of cross-check some of the work that we're talking about here with some similar goals with that commission as well, so that we don't unnecessarily duplicate efforts. And if it's possible to bring alignment to those efforts, I think it would be good to at least consider seeing how the two scopes fit.
Yeah, and I think also Rachel, Dr. Holbershorn, it used to be Cirilla, now do the mental health task force. So we could even ask them to come one time and we can share what we're doing as far as the education one, and then what they're doing as far as mental health.
Okay, do we want to plan that for the next subgroup meeting?
Sure.
Okay, Bethany, is that something that you all are able to add to to you all's to-do list, the legwork behind that?
Absolutely, yeah, I can. Is it Dr. Holvershort now who is chairing?
I'm pretty sure it is. Yeah, I'm pretty sure it's her.
Okay.
Great.
And Cirilla is still there, so I mean, I can always check with them to see if they could be available for that next meeting. Are we talking to have them join us for our next subgroup meeting?
Yeah, just to make sure we're not like, if our objectives and goals are crossed, if they're the same, how can we connect them? We don't want to do the same work.
Okay.
That's great. That's a good idea. All right, anything else? Well, on that note, thank you all so much for being here today and for being so candid and helping us flesh through this first meeting. I think we have a few really good intentional areas of focus that we can move forward with. And I am excited to see what we are able to do. I think there's a lot of really awesome potential here within this group. And yeah, it's just very exciting. So thank you very much. If you need anything in the interim, please don't hesitate to reach out, and we will be in contact soon. Thank you, everybody. Have a good rest of your day.
Good week.
Thank you.